Okay, sorry, I forgot to hit record. All right, we're recording now. So, what did I say? Okay, so the
You're
depth.
talking about the location of the
Location.
burns, if the eyes or the
Okay, all right,
no.
very good. So the second factor is the location. So which part of your body was burned? Let's say if it's the eye, even if it's a minor burn, but it's the eyes or your hands, for instance, or your feet, your legs were burned. So that makes a difference. Meaning you can't see, so how can you take care of yourself, right? So we have um, ADL issues to consider, mobility issues, that kind of thing. Um, Also, if you got burned in the perineum, okay, or in the axillary or perineal areas, so that will be a problem because these areas aren't the cleanest parts of our body. They're naturally growing bacteria, so they may not heal properly. The third factor is the extent. Extent will be how much of the body surface area is burned. Okay, um, so we will learn about calculating the total body surface area (TBSA). For our purposes, because we are not specialty burn nurses, we will only be using the simplest, which is the rule of nines. And then finally, the fourth factor that affects the severity is the patient's personal factors, meaning if a patient between a healthy 16-year-old and a diabetic 49-year-old, so there's a difference there because obviously the diabetic older patient has a um, lesser ability to heal, okay, compared to the younger 16-year-old otherwise healthy patient, right? So these are the things that we have to consider with the severity. They're all mentioned here. So I mentioned the depth, we also the TBSA, and then I also talked about the location, um, and I don't know where the comorbidities fall, but it's somewhere in the chapter. So one of the things in your blueprint, let me show it to you. Right here under burns is oh, I missed that part. Okay. Do I have manage? No. Ah, right here, determining the depth of burn injury. Okay, so line 41, this would answer that test question. So the only way to recognize it is to know table 26-1. This classifies it according to the depth. So we have superficial burn, superficial partial thickness, deep partial thickness, full thickness, and deep full thickness. So the American Burn Association has expanded it to the simple first, second, third, and fourth degree burns to now 5 burn classifications. So the color, to help you remember here is what is burned, how far is it burned. So if this visual here, we have a figure down here, figure 26-1. If this one helps you, it's really how you remember the appearance is how many layers is burned. So for instance, if it's superficial burn, it's only the upper here. So therefore there is rich blood supply still available. So that's why it will explain why it looks the way it is. So if there is still blood flow, so of course the color in superficial is still pink to red, as well as superficial partial, still pink to red. Deep partial thickness, now it turns from red to slightly white, meaning is there still blood flow in, meaning is there still normal blood flow in deep partial thickness when it already looks white?
No.
All right, so some areas now of the burnt tissue don't have blood supply. That's why they turn white. And then the deeper you go, now they turn black, brown, yellowish, and then deep full thickness, it's all black because you burned through several layers already. Um, so that's why it looks black. And then edema, this again has something to do with the vessels. Okay, so in and also the tissue layers. So if in more superficial,
I'm sorry, I only see your blueprint.
oh, sorry. All right, so table 26-1. So in edema, so there will be mild edema and superficial, and then mild to moderate and superficial. And as you can see, the more severe the burning, so right, like right here, for instance, in deep full thickness, there is no more edema. There is the most severe edema is in full thickness because there is now massive amount of vessels that were burned, and all those vessels go into severe inflammation. And what I mentioned at the start of the class was the increased capillary membrane permeability. Okay, so that will lead to more edema even in areas wherein there is no burn. So let's say we only burn half your body, but you'll see that patient will have edema in the upper part of the body as well, from head to the waist. There will also be considerable edema. So that explains the reaction that it is systemic. Okay, there is systemic increased capillary membrane permeability in response to the severe injury that triggers the inflammation. Pain, of course, in deep pull thickness, absent, but as you learned earlier, all burn areas are painful. So there will still be some dull pressure type pain there. Blisters, of course, no blisters the deeper you go because there's no more skin. The only way you'll have blisters is if you still have intact skin. So that's why blisters is only seen in superficial partial. But there's no blisters in superficial, which is a sunburn, number one example, because the burn wasn't that deep. Eschar, of course, no dead tissue in superficial. Then you have several eschar now the deeper you go, more dead tissue. Healing time also takes longer the deeper you go. We will not discuss grafts because the reason is I mentioned at the start, we are entry-level nurses. We are not expected to work by NCLEX, we're not expected by the National Council to work in a specialty burn unit. And here are finally examples of the burns. Okay, and later on we'll look at the causes of burns because it's not only heat that causes burns. We will not test table 26-2. This is only for specialty burn hospitals. This just tells you who should be sent to a burn center, a specialty burn center. Here it tells you it's not always severe burns. So let's say even if you have a minor burn but is affecting these areas, for instance, see it says any burn. So it doesn't have to be a severe or a deep full thickness burn. But if it's involving these areas here, which are important for ADLs, okay, so these are serious injuries, so they go to a burn center. I'm getting the descriptions.
Professor, don't the is that don't the the eyes and the ears, sorry, the eyes, any burn from the face, does it, don't it also affect the respiratory issues?
Yes, yes, but in burn injury, we also look at those are separate. Those are called inhalation burns. So yes, that's a different problem. Okay. Another reason why it's the nose ears also is these areas are made of cartilage, right? Like the nose and the ears, these are cartilage. So in the first place, they don't heal very well because they have very little blood supply. And plus, as you said, facial burns, neck burns, or upper chest burns, for instance, facial burns, is always accompanied by inhalation injuries. Nobody really exhales, right, when they're scared. Like when you ride a roller coaster, for instance, you have a 90-degree drop at um, 100 miles an hour. You don't exhale, right? You inhale, you go, you always gasp when you're scared. So when you're burned, I don't think you're gonna exhale. Okay, so you're not expecting that. So you tend to inhale when you're on fire. So you will inhale the fumes. Okay. I was saying earlier, the questions are not only on the table. So I did not get the descriptions strictly from table 26-1 because they're very little. See, they're only a few words. So I got the terms in the paragraphs. So I got them from here because they give me more description. So this is what I cut and pasted on your exams. Questions so far?
No.
Okay. Here's an example. These are burned injuries. So these are, see how edematous the area looks now. So this is superficial partial thickness. You have the skin burnt off here. The epidermis is burnt off, and you have the dermis exposed. Then you have several blisters here, right? And this is well done. This is medium well, all right? And this is overcooked. This is burnt already, so I'm not gonna eat this. So you have several eschar there. Um, Before we go any further, because they mentioned circumferential burns here, the concept of compartment syndrome. So we talked about it in increased intracranial pressure under traumatic brain injury, and also you guys talked about it under musculoskeletal injury and under fractures, and then now this time under burns. Now, as explained here, as described here, if you have a circumferential burn, meaning the whole circumference of the arm, the leg, or the torso is burnt, the burnt skin, especially this one, okay, or here, the skin becomes very tight, okay, and the skin is still intact, but then it, as described up here, the skin now becomes hard, inelastic, leathery, right here. So the skin, the deeper you go, becomes hard and inelastic. So plus there's swelling of the tissue underneath. The hard, inelastic skin acts like a tourniquet. So it will prevent the swelling from increasing because it's now very hard and leathery. So that will result in a compartment syndrome. Same exact concept in compartment syndrome in fractures or in burns. Okay, there will be compression of the vessels, so there will be ischemia, so the six P's will appear because there's no more blood flow, there is no more um, blood drainage either, and then there is also no blood flow to the nerves. So you'll have the six P's. You'll have the unrelieved pain, you have pallor, pressure, paralysis, paresthesias, and pulselessness. Okay. Um, we can do, I mean, the doctor can do fasciotomy if it's required that deep. However, they can also do only escharotomies. You have pictures here. Here, this is an escharotomy. So they did not make the incision deep into the muscle. So this is just to cut through the hard, inelastic, burnt skin. Okay, just to relieve pressure to restore blood flow to the periphery. Okay, because otherwise, again, this really thick um, burnt skin will act like a tourniquet. So they'll make strategic incisions. They don't just cut anywhere. Of course, they study these things, so they can make strategic incisions to relieve the pressure. Okay, they can do the same on the torso. So let's say your entire um, anterior or posterior chest wall is all burnt, so you'll have really crispy skin, like chicharron. So they'll have to make several incisions there in order to allow for chest expansion, because otherwise you can't breathe. Okay, the skin will act like a really tight binder around your chest, preventing chest expansion. So you should watch out for those. Again, anytime you have a circumferential burn. So here completely surrounds an extremity or the chest. So that's a circumferential burn, and the doctor may need to perform an escharotomy or a fasciotomy. All right, so I discussed the vascular changes that occur. Again, this occurs during the first 24. It's 24 to 36 hours. Okay, not 48. So we don't know how long exactly this will start and stop. We just know that it occurs between that period, okay, anywhere between 24 to 36 hours after the burn injury. So the edema here, the extensive edema, even in areas that were not burned, as I mentioned earlier. So this will affect the entire body. So there will be fluid leakage both in the burnt areas as well as the non-burnt areas. So when you look at this patient, they will have severe edema from head to toe. So that is what I mentioned earlier as the relative fluid loss. Okay, so the fluid is not only being lost um, from the body, but also it's also lost from the uh, through third spacing, meaning they're in a compartment where the body can't use it. Give me a second. Any questions so far?
No.
No.
Okay. All right, let's talk about the the electrolyte changes. Okay, so in a burn injury, imagine there is fluid shifting. Also, although the patient looks edematous, are they in fluid overload or fluid deficit?
Deficit.
They're in deficit. They just look like they're in fluid overload because of all the edema, but remember that all that third spacing means that the water left the intravascular compartment as well as the intracellular compartments, and now are all in the interstitial spaces. Okay, so the patient will have hypotension, severe dehydration, and how long does this last again? This condition wherein they have a leaky um, vessels?
24 to
24
24
36.
to
vessels. So
30.
24 to 36 hours. This patient will be extremely volume deficit. Um, so we have a very dehydrated blood sample, correct? So plus add to that all the dead cells that were burned. So what electrolyte imbalances do you expect to see? So during the first 24 to 36 hours, there will be hyperkalemia because of all the dead cells. Okay, they will spill all that potassium into the bloodstream. Um, the patient will be losing the sodium into the interstitial space. So that's why you have hyperkalemia and then hyponatremia. And as I already mentioned, there is hemoconcentration because of a very concentrated blood sample because all the water is now in the third space. Now let's go to the next phase. So after the first 24 to 36 hours, what follows is now fluid mobilization. This is the equivalent to the diuretic phase of um, acute kidney injury. So if you remember AKI chapter 68, the patient during the first 24 hours of AKI went into the oliguric phase, correct? They stopped making urine. However, during the diuretic phase, this increased capillary membrane permeability stops now. So the vessels stop leaking fluid, and as a result, now you have water returning to the vascular compartment now. And this occurs around 48 to 72 hours after the burn injury. So now you go from hyperkalemia and hyponatremia to now hypokalemia. The sodium remains low at this point because they are here. So there is still hyponatremia and hypokalemia at the same time. Questions so far? You need to know this because one of our graduates, of course, we don't want you violating the honor code of the NCLEX because you're supposed to sign and say, you won't ever talk about the NCLEX exam and the questions ever. But nobody really follows that. Graduates come back and in their excitement, let me just put it that way, in their excitement that they pass, they tend to share, yeah, I got this question and I got it. Two students had this question, all right, asking them what are the changes during the first 24, and then the other had a question about the 48 to 72 hours, and it was select all that apply. All right, so you need to understand this part here. So there's some purpose to it.
So, Professor,
Yes.
during the first 24 hours
Uh-huh.
would be the fluid deficit, and then the next 2 to 3 days would be the opposite.
Yes, that really depends on if they make it to the 48 to 72 hours. So let's say they make it, right? So here clearly says fluid mobilization starts after the 24, so this is now 48 to 72 hours because the capillary leak stops at this point. So therefore, fluid returns to the vascular compartment. However, this doesn't mean that the patient is, out of the woods now, because we need to, this is the crucial period, because let's say your nurse didn't monitor you properly, because imagine what without showing you the interventions, what do you think will be administered during the first 24 to 36 hours? How do you maintain this patient's fluid status?
I guess IV.
All right, so we're giving massive amounts of IV fluids here.
Mm-hmm.
Now, the patient won't say, "Oh, I'm ready for this to stop now because I think I'm fluid. I'm fluid mobilization is occurring. I can feel it." So this patient most likely is intubated. Okay, they're
Mm.
unconscious. So the nurse is the only one watching all these. So let's say your nurse misses this point. Okay, does not notice the diuresis that's now occurring. Okay, because we go from here wherein the patient's really pretty much in shock, hypovolemic shock, to meaning there's no urine output there, very little, if any. You have either anuria or oliguria, to now you have diuresis. Okay, and
Mm-hmm.
imagine if you're still continuing the massive amounts of fluid here, so let's say 1 liter per hour, what happens when this period begins?
Uh,
Yeah. Could it be fluid
Dehydration.
overload?
Fluid overload,
Fluid
Okay.
overload.
right? Because now you have the capillary leak stops, so the patient's no longer losing fluid, at least not relatively. Okay, the patient's fluids from the interstitial space is now returning to the vascular compartment. So that adds to the 1 liter per hour that you're already giving this patient. So potentially this patient might go into fluid overload. So that's why it makes these first 1 to 3 days extremely crucial. All right. So again, please do not forget the electrolyte changes. Okay. I won't discuss in thoroughly the cardiac and pulmonary changes because these are really the same mechanisms we talked about in shock, which was it last week? No, 2 weeks ago. Okay. So these are as a result of the compensatory responses. Okay, the sympathetic nervous system response, the renin-angiotensin aldosterone system, because this is you're losing fluid, so blood pressure is low, so this will automatically be triggered. So you have the antidiuretic hormone response from the hypothalamus. So all these are responsible for these signs and symptoms. Okay.
Yeah.
On top of that, though, we will talk about the inhalation injuries separately. It's discussed on a separate section because it takes special care. So here you have no peristalsis. Okay, peristalsis decreases at least, and in some cases you'll have ileus, absolutely no motility. Because this is a severe injury, the patient will develop stress ulcers, or specifically for ICU patients, we call it Curling's ulcer. So, of course, interventions would include you give prophylactic proton pump inhibitors here, or even H2 receptor blockers, okay, to anticipate the development. Metabolic changes, because this is a severe injury, the patient's metabolic rate increases, so their nutrition, um, they require higher calories now because they're burning their calories at a so high rate because of the injury. You're trying to respond to an injury, you're trying to heal, so they'll be requiring up to 5,000 kilocalories a day during after a burn injury. Immunologic changes, of course, this will have your immune system in a hyperactive state. Okay, there's severe inflammation, and of course severe, which will actually increase the edema, because now you have white blood cells going to the area. Okay, so and then of course there is some contamination here of the wound, so this will add to the swelling and the edema. And this is where sympathetic again response and the RAS. Okay, so let's go now to causes. So burns can be caused by heat. Heat can be dry or moist. We can also have chemical burns. We have electrical burns, and then we have radiation burns. Most common causes, of course, is heat. So that the heat can either be dry, like a fire, or it could be scalding hot liquids. Okay, so somebody throws boiling oil at you, or say accidents during Thanksgiving, for instance. Contact burns, touching hot surfaces, which is metal, tar, grease, or like from a motorcycle exhaust pipe, for instance. Okay, I remember my sister had a nasty burn from that. Chemical burns, which there are two kinds of chemicals. We have acids and alkali. So either one um, can cause burns. So either acids from bathroom cleaners. We also have alkali based like Drano, for instance. Okay, so these chemicals can burn. And then we have electrical injuries. This type of burn will have the least amount of damage to the skin. Most of the damage caused from electrical injuries are to the vital organs, or to any organ, for that matter. You'll only see probably one or two wounds after an electrical burn, because you'll have an entry and an exit um, burn, unless the patient catches fire, because it's also possible that after you come in contact with the electricity, it may burn your clothes, for instance. So in that case, then you may also have um, other burns caused this time not by the electrical injury, but heat. Okay. So here's an example. So here's the entry, and then you may have an exit here. Or let's say you're really unlucky. Okay, it can enter in one testicle and then exit out of the other testicle. Okay, so that would be the worst. So here are again electrical entrance and exit wounds. In my work experience, I've seen it only once at the hotel where I used to work. One of our electricians had a pretty bad electrical burn, and it was like a stigmata, because the entry was on his left palm, and then the exit was on the other palm. Finally, radiation burns. We already covered radiation burns in chapter 22 under cancer treatment, because that was radiation therapy, though. So we had radiation damage there. Um, Radiation can not only come from therapeutic radiation, which is what we use for cancer treatment, but also in industrial settings. Let's say you work in a nuclear power plant, um, or making nuclear weapons. Okay, so those are still radiation. All right. Prevention. You wouldn't believe the question they get on the NCLEX. So for the few students that came back, did you get any questions on burn prevention? Yes, we did. And the questions was something you would never imagine they'd ask. It was about the number of smoke detectors in the home, how often you change the batteries, that kind of stuff. So we do have that covered. Okay, so this section of the book tells you right here recommendations that each bedroom has a smoke detector, one in each hallway, in each story of the house, and then one for the kitchen, the stairwell, and the entrance, right? So we have that part covered. Um, the rest of these, I mean, these are things you would imagine that we should know already, but you wouldn't believe some people wouldn't know this. Um, I mean, these are standard safety. You wouldn't dream of doing these things, but I guess it happens. Well, I shouldn't say that. My dad did my late father did cause fire in his bedroom. Wasn't that much structural damage to the house. It was his bed. It was his bed. His bed was um, gone. Okay, and of course we had some burn on the ceiling in his room. He was smoking in bed, so he left. So his pillow got burned first, and the rest of the bed followed. All right. So before we go into the other management, I'll only cover the emergency, and then we'll go on a break. Um, there are phases of a burn. First is the resuscitation phase. Other textbooks have an initial phase, but the initial phase is pretty much the same as chart 26-1, which is the pre-hospital phase. So we can say that this author put the initial stage under the resuscitation phase. Okay, so this will cover first aid because, I mean, do you plan being burned inside the hospital? No, right? I mean, burns occur outside the hospital, and so you have to take care of the patient in the field before they come to the ER. All right. Um, so of course it's ABC, but please use common sense when you read this chart. The first part here says general management. It says ABC, right? But when you go here, specific management, this is specific now for each type of burn. So we have flame, burns, chemical, electrical, and radiation. Okay, fine. However, when you do this, so let's say airway patency and give oxygen, right? I mean, if the patient is on fire, you can't put oxygen, right? So it's impossible to do that. So just use common sense. Of course, you'll have to smother the flames first and smother, anything burning, put that out first before you put oxygen. All right. So I won't give you all the scenarios. Please just use common sense. So let's just put it as when safe, okay, assess for airway patency, give oxygen, cover the patient. Of course, we put them NPO because these patients may have inhalation injuries. Elevate the extremities if no obvious fractures. This is, of course, to increase venous return because the patient automatically loses water and has low cardiac output beginning at the time of the injury. Obtain vital signs and then start a line if you can. Okay, remember it'll be harder to start a line as the burn injury as the time lapses because the patient's edema will only increase. So it'll be extremely hard to start an IV line once edema has already set in. Remember, the patient's edema will be head to toe here. It won't just be the burnt areas. Okay. Tetanus toxoid, of course, because this is a serious skin injury, so you can be you're at risk. And please read the rest. For chemical, unless you're an expert on the chemical that caused the burn, then but if you don't, I mean, you don't know what the neutralizing agent is, then don't bother, okay, because you may cause more harm. So the general principle is if it's a dry chemical, then don't wet them, and then vice versa. If it's dry, brush them off. Remember that um, what's this? Chemicals, whether acid or alkali, continues to burn as long as they remain on the skin. So if the clothing is doused in it, then remove that clothing because that will continue to burn as long as it's in contact with the patient's skin. I already said this. This one, most companies, if you have any harmful chemicals, whether acid or alkali, you will be required by OSHA to have a MSDS anyway. There's a book somewhere in the company telling you what the chemicals that are used in the facility. Okay, that's required for licensing. And electrical burns at the scene, if you can turn off the power supply. If not, then try to separate the patient either using a stick or any other um, um, non-conductor object. If they're on fire, of course, that will now be a flame burn. So the other thing applies. Because electrical burns damage internal organs, so it's not uncommon for these patients to go into cardiac arrest. So do CPR and ECG. Radiation, as already said, this is the same thing we did in chapter 22. But for industrial radiation, there has to be decontamination. So the routine is a shower to wash off the radiation from the patient. And we'll stop right here. We'll take a break. Come back at 5 minutes after 7.